go on to our last speaker, Dr. SUNEETA DUBEY, and I'm so sorry that you're the last speaker and you've been unwell, and the way you sat through it and gave your expert views. I'm so thankful to you, and let us hear your very interesting talk on an overview of Glockmar drainage device and their complications. On to you, Dr. SUNEETA.
Can you see my slides?
Yes.
Yeah, so thanks a lot, Dr. Chitra, for having me for such a wonderful and extensive webinar. As you know, glaucoma drainage device surgery has become one of the most commonly performed and dependable glaucoma surgical procedures, especially for secondary refractory glaucomas and even in some complex primary glaucomas, with significantly improved long-term outcomes with better designs, material, and technique. A thorough pre-operative evaluation is a must, and a meticulous planning for surgery is a must before going in for glaucoma drainage device surgery. One needs to assess for associated comorbidities like uveitis, neovascular glaucoma, previous complicated surgeries like VR surgery, squint surgery, which may be associated with scarring and may affect the type of the implant and the site of implant. And also the presence of associated comorbidities like vitreous in AC or neovascularization or inflammation needs management of the primary pathology to prevent post-operative complications. Also, the two very important determinants for deciding the position of the tube are the extent of PAS and the status of lens, and they're going to decide if they are going to put the lens in the tube in the anterior chamber or in the sulcus or in vitreous. I will discuss here this post-PK glaucoma, a young male who underwent penetrating keratoplasty recently, and he came to us with a clear graft and with very high pressures. And as you can see, there's an extensive PAS 360 degrees and IMSC and a near total cupping. He was not controlled with maximal medical therapy except glycerol and mannitol, and we decided to do phaco with IOL with AGV. So I feel in such complex glaucomas, a combined procedure is a boon, and the cataract surgery was performed with the temporal incision. The pupil, as you can see, was already dilated, and the cataract surgery, the phaco was done, and the intraocular lens implantation was done. And then the superior-temporal quadrant was chosen for the AGV implantation, and after priming, the plate was fixed 9 millimeter away from the limbus. I use 90 nylon suture for the fixation of the plate, the tube fixation, and also the scleral patch graft suturing. Sorry. So since there was extensive PAS, the tube was planned to be put in the sulcus. Viscoelastic was injected while inserting the needle so as to dilate the sulcus, and then tube was inserted into the sulcus. And since the pupil was already dilated, the length of the tube is such that it was visible through the pupillary area. So the tube was fixed with nylon suture again. And then this scleral patch graft was used to cover the tube. And then the conjunctiva was sutured. So this is the post-operative picture, and this patient is doing extremely well 4 to 5 months after surgery with the IOP well controlled. So post-operatively, like any other glaucoma surgery, you have to use steroids, antibiotics, cycloplegics. One needs to monitor for the hypertensive phase, especially in the valve implants, and hypertension or low IOP can be there in the immediate post-operative period. It could be because of peritubal leakage or malfunctioning of valve implant or oval filtration or incomplete occlusion of non-valve implant device. So it's very important to take care of all these factors, and it could be because of some non-device related complications like severe inflammation, choroidal detachment, or cyclitis. And as in trabeculectomy, the hypotony is more common in patients with myopia and ophthalmic eyes. But if sometimes, if it is transient in most of the patients, it can be controlled with conservative treatment. Non-valved implants, the valve implants are associated with hypertensive phase, and it begins as early as 2 to 6 weeks and may last for 4 to 6 months and resolves with remodeling of bleb. And as we know, the cause of this hypertensive phase involved implant is early exposure of conjunctiva and Tenon's capsule to aqueous with pro-inflammatory cytokines, inducing early fibrosis and scarring. And there can be other factors too, like multiple surgeries or the smaller size of end plate or polypropylene rigid plate. So aqueous suppressants are now widely prescribed to prevent hypertensive phase. And if you start aqueous suppressants early in the course of post-operative period, then you can prevent hypertensive phase to a large extent. And then other procedures like bleb needling, removal of cyst wall and all are not so effective in case of implant surgery as in case of trap. A very simple procedure is that you can just tap the bleb using 30 gauge needle on slit lamp for to release the tensions of these high tension bleb, although you need to do it several times. It may alter remodeling of the bleb, but results are unpredictable. Coming to complications, the implants are associated with a unique set of complications which are related to implants like outflow obstruction, conjunctival erosion, implant exposure, tube migration, or diplopia. In the early post-operative period, since we are doing complicated cases, it may not be uncommon to see the proximal end of the tube being blocked by blood, fibrin, iris tissue, lens, or vitreous. And it may be transient and it can retract, especially blood and fibrin with topical steroid and cycloplegics. And even iris strands and vitreous strands, if they're small, can be managed with low energy YAG laser spots. But in some cases, a surgical intervention may be required. So in this particular neovascular glaucoma patient, a low energy laser shot could retract the clot, as you can see, and in another patient too. So most of the times it can be managed with conservative treatment. If the tube is in close proximity to the iris and if there is iris incarceration, it too can be managed with a low energy YAG shot, as you can see here. Vitreous, if it is a thin strand, then can be cut with YAG shot. Otherwise, one has to do vitrectomy. A common complication which is present in 2 to 8% of patients with tube implant is conjunctival erosion or wound dehiscence. So wound dehiscence occur early in the course of post-operative period, and the tube erosion occur a little later. And this conjunctival erosion, if the conjunctiva is relatively healthy, then can be treated conservatively. And doxy does have a role with a lot of lubricants and steroids, and the conjunctiva can get epithelialized over a period of few weeks. However, if there is tube erosion, then immediate intervention is required because there is a risk of endophthalmitis. And tube erosion generally occurs in patients who do not have a very healthy conjunctiva, or there is excessive tension overlying the tube. It could be because of immune-related inflammatory process or repeated mechanical force caused by eyelid blinking and rubbing. And that is why it is can be seen in children as well. The long scleral tunnel technique can prevent it to some extent, and also the tube which enters the eye at 12 o'clock rather than at 10 to 2 o'clock can prevent tube erosion to some extent. But if the tube erosion happens, it has to be treated surgically. You need to dissect the eroded conjunctiva, fix the tube to the scleral bed, and when you suture it, it lies flat on the scleral surface, and which prevents the movement of the tube. Patch graft, either scleral or any other patch graft, can be used to cover the tube, and the conjunctival advancement if the conjunctiva is not necrotic, but if the conjunctiva is not healthy, then you need to use conjunctival pre-graft or autograft, and the pedicle graft if the conjunctiva is thin, scars, or avascular owing to numerous previous surgical procedures, because the pedicle flaps allow the importation of distal vascularized tissue to the area. Sometimes you have to use amniotic membrane grafting with fibrin glue to put everything together. Post-operative hypotony can also be commonly seen in patients because of various reasons, and a very simple technique wherein you can just put an intraluminal stent. You can use a 3-0 proline or 4-0 proline in this particular patient who had undergone multiple surgeries and even cyclodestructive procedure before this tube implant, had severe hypotony. So 2 stab incisions are made. One is opposite to the tube and the other adjacent to the tube. And then with the help of microforceps, grab the tube and insert this proline suture into the lumen of the tube. This is 4-0 proline, and it doesn't completely block the tube, but maybe 65-70%. If you want to completely block, you use 3-0 proline suture. So to conclude, meticulous preoperative workup and surgical technique is a must. Frequent follow-ups to recognize the early complications. You need to recognize the hypotony, you need to recognize the hypertensive phase and manage them in time to improve long-term success of your surgery. Thank you very much for your kind.
Thank you very much, Dr. SUNEETA. That was a wonderfully amazing talk. We always keep for the best for the last. So I would want Dr. Susmita to also be involved in the 2-3 questions I'm going to ask her. How do you prevent or manage entry site leaks with the Glockmar drainage devices?
So, okay, sorry. Sunita, go ahead.
Go ahead.
No, it's okay.
Okay, so I think using a 25 gauge needle, even though it sort of is a little tricky to get the tube in, but that's the best. But having said that, I must confess that I find it very, very difficult. So it's easier to go in with a 24 gauge, but in that case, I would use a longer track, a longer scleral track, rather than enter right at the limbus. And the other thing is sometimes the tube entry at the end of the day is the most tricky thing, because somehow it never goes where you would like it to be. It goes everywhere else. The other small trick that I've learned from Ronnie is to enlarge just the inner part of the incision, and then the tube sort of, it funnels inside rather than outward, and that again. And the third thing that has helped in insertion is using viscoelastic and injecting it while coming out. So lubricate the passage so that it goes in. But otherwise, you just keep doing it.
Have you ever implanted a second GDD, or have you tried doing a needling for a failing drainage device?
We used to need to, in fact, do capsular excisions, because with the AGB, especially in young patients. But ever since the ADI has come on the block for young patients, I don't need to do any excisions after that. And the excisions never worked. Within the period of 4 to 6 weeks, they come right back. And yes, sometimes I have implanted a second drainage device, but only after I have exhausted multiple DLCPs with transillumination. But rarely I have had the occasion to do that.
So one thing I have observed is, if you have used DLCP and if you again do another glaucoma surgery, then the chances of ciliary body getting compromised, or it's not optimal. So the chances of hypotony is much more. I showed in my last case that the patient had undergone transscleral cytophotocoagulation, and after doing this AGV, she went into hypotony. So I think.
Is there a special implant size in children?
By the time a child requires a drainage implant, is usually ophthalmic, and we don't need to. So I've never put a smaller plate. I haven't needed to.
Or maybe you could trim it also, I suppose.
I think as our hair grows grayer, GDDs in children is a bad idea. I mean, they do well for 6 months, 1 year, but you follow them long enough, they rub. So there's nothing you can do with a child. He's going to rub. I've had erosions, and now I've become more and more conservative in children, frankly.
Any other question from the other speakers, or shall I go to my conclusive remarks? I'm very sorry we are ending it later. I suppose there wouldn't be any questions, and I'm so sure that we all agree on one score, that it has been a truly wonderful webinar, and I learned a lot. I'm not sure about all of you. And on behalf of ARC, a most heartfelt thanks to the very expert panel and a truly superb set of speakers. My thanks are due to Dr. Shailesh, who was such a supportive partner, and he gave me so much energy along the way. And my thanks are due to my ARC panel too. Thanks to Mr. Kripal and the AIOS team. Thanks a lot, Sai and Manjula, for the innumerable mails you helped me to shoot to all the AIOS members. Dr. Anand Sethi, I goes without saying, all of us in these webinars know how efficient he and his team is. And my most heartfelt thanks to Sun Pharma for sponsoring all our PG update related webinars. And finally, and most importantly, my thanks are due to our very dear attendees for making it so worthwhile. Thanks a lot, everybody. Thank you so much.
Thank you.